me, right? Morning, everyone.
Morning.
I have a beautiful bio for our speaker, so when I have them, I think I should use them, but I think everyone knows Laura Bamford. But it's always nice to hear a little bit more about what people do, so, and where they come from. So Dr. Bamford, Laura, completed her internal medicine residency at Columbia, an ID fellowship at University of Pennsylvania, where she also received her Master of Science in Clinical Epidemiology. I don't even know where to look. At the owl. And she's a clinical professor of medicine in ID and global public health and the director of the Owen Clinic. Her clinical and research interests include HIV and Hep C treatment and prevention in people who use drugs. She's very passionate about delivering patient-centered care and research with a low barrier and harm reduction approach. There's a lot of good stuff here, but now I'm gonna, we'll get to it now. So she currently provides substance use disorder treatment integrated into HIV primary care at Owen Clinic and is a member of the UCSD Addiction Medicine, Pain Medicine Committee and the UCSD Opioid Use Disorder Task Force. And she serves as the coordinator of the newly mandated substance use disorder rotation at UCSD for all internal medicine residents and was recently appointed to the board of directors at Stepping Stone San Diego. So with that, I will turn it over to Dr. Bamford and I'll keep an eye on the chat and we'll try to only bother you for clarifications.
I wanted to interact with you.
Okay.
Thank you. Thank you so much, everyone. All right, so we'll get started. I'm going to talk about it's become part of my mission here at UCSD to integrate harm reduction based substance use disorder treatment and really improve the care of people who use drugs at UCSD. And I have no disclosures. And so I like to talk or start every talk related to substance use about the importance of the language that we use, because that really shapes the way we treat our patients, the way we treat our research participants. And so throughout this talk, and I hope, throughout all of your days that you'll adopt this language and, say things like substance use disorder or a person with a substance use disorder instead of an addict or a junkie or a user, and say things like, again, someone with a substance use disorder, not a drug habit or abuse or a problem. When we talk about tests related to substance use, when we talk about urines as dirty or clean, but positive, negative, expected, not as expected as we do with any other test. And then finally, not talking about when someone returns to use, not calling it relapse, but calling it really what it is, return to use for one day or return to daily use. All right, and then we're going to weave harm reduction, I'm going to weave harm reduction throughout this entire talk. Because as I said in the beginning, this talk is about integrating substance use treatment at UCSD, but we have to recognize that there are also people that aren't ready for treatment or don't have access to treatment because of insurance barriers or other demands, work demands, childcare demands, or again, they're just not ready. And so part of this is also improving the care for people who use drugs, and that's really what harm reduction is all about. And so these are policies, programs, practices that aim to reduce the harms of substance use in people who are unable or unwilling to stop. And then it's really the defining features are the prevention of harm rather than the focus on the substance use itself. And the focus on people who continue to use drugs and help them do so in a safer way. All right, so we're talking about this because, as you all know, we're in the midst of a fentanyl and stimulant epidemic in the United States. And until 2021, for the decade that had preceded that year, we saw an exponential increase in overdose deaths, mostly related to fentanyl, unprecedented in U.S. history. And now there's finally, some cautious optimism that in the years 2022 and 2023, we finally saw a small decline in overdose deaths. And that's largely in part to syringe service programs and expanding treatment and just education. Where we haven't made the same inroads is in stimulants, and this really is dependent on which coast you live on. So see far more cocaine on the East Coast, and as you all know, we see far more methamphetamine. That's what psychostimulants are, really mostly methamphetamine, and actually overdose deaths are actually increasing in both cocaine and methamphetamine. And that's thought to be because so in a big national survey called the National Survey of Drug Use and Health, it actually found that use of methamphetamine is really diversified to populations that weren't known for prevalent use. It's historically been used mostly by middle-aged white men who have sex with men, and now it's really diversified to all demographics. And also, people report using methamphetamine in riskier ways, which I think really corresponds to the death. So going from snorting or smoking to injecting it. And then thirdly, the methamphetamine that's available is far more potent than it was in the past when it was derived from pseudoephedrine, and the United States really locked down like all Sudafed in pharmacies, and so the cartels and manufacturers turn to other compounds, something called P2P, which is pseudopropanone, and it is really found in all industries, so really hard to crack down on it, and it is far more potent and neurotoxic, and so that's why we're seeing far more overdose deaths. All right, and then what is the story here in San Diego? Also, I think some cautious optimism that we are overall seeing a decline in fentanyl overdoses as of the end of 2023. What is interesting here in San Diego is that unlike the national numbers, so the blue line is all opioids, and that actually does include fentanyl. So you can see the orange line, just fentanyl. So most, again, all overdose deaths are involving fentanyl, but far more deaths involve methamphetamine than elsewhere in the United States. And that can be methamphetamine alone or methamphetamine that's contaminated with fentanyl. All right, and then this is the age-adjusted overdose death rates by region. So, here we sit in Central Region, where we have, where we are here in Hillcrest and La Jolla, the highest death rates in the entire county. And these are age-adjusted because most overdose deaths do occur in people between 18 and 45. So, both Central and East, and we now have East Campus, really, I think, it's the responsibility of UCSD, to take this on and really address, these epidemics. Right. And so in addition to overdose deaths, there's endemics with increased use of fentanyl that also impacted new HIV diagnoses. And so for, until about 2014 or so, we had seen a 30-year decline in new HIV infections amongst people who inject drugs. And then there was this first outbreak that I think many are aware of in Scott County, Indiana, a county that had had like no HIV diagnoses for several years. And then all of a sudden, a new synthetic opioid called oxymorphone hit the streets there, and there were in just under a year and a half, 215 new cases of HIV. Majority of them also tested positive for Hep C antibody, so clearly a marker for shared injection equipment. And then there was this larger, and that wasn't part of this larger study that was published in JID, but this was a larger study that looked at several outbreaks across the country, between like 2016 and 2018, in Seattle, Portland, Oregon, Philadelphia, all places that have, very well integrated service programs. And despite all of that, we saw a lot of new outbreaks. And again, amongst people who inject drugs, the majority of these people also were Hep C antibody positive. And then lastly, I just learned of a new outbreak in rural Maine. So between October of last year and, this is still kind of ongoing, just, through this month, we've had 14 new cases in Penobscot County, Maine. And in the previous 5 years, it had 2 diagnoses per year. And I talked to Stephen Rawlings recently, who is a ID fellow here, and he's helping the state health department in Maine try to get PrEP to people who inject drugs in this county there. All right, and then in addition to HIV, we've seen also an exponential increase, like 4-fold increase in hepatitis C infections in the last decade or so. Also some cautious optimism here that things are finally declining over the last few years, but nowhere near the target of where we want to be to reach Hep C elimination by 2030. It's thought that we've seen these reductions again because of fringe service programs, getting people into substance use treatment, expanded access to direct acting antivirals, but still a long way to go. All right, and then some other harmful outcomes of these epidemics. So in the background of these overdose deaths and increased HIV and Hep C infection, we've also seen enormous increases in hospitalizations for serious bacterial infections like skin and soft tissue infections, infected endocarditis, epidural abscesses, and osteomyelitis, all in people who inject drugs in this country. And the worsening methamphetamine epidemic has also increased hospitalizations and increased length of stays and in hospital mortality, which we've attributed to worsening psychiatric disorders, skin and soft tissue infections, and also congestive heart failure. And in the United States, 1 in 9 hospitalized adults thought to have a substance use disorder, so 11%. But only about 6% of individuals in this country actually receive treatment for substance use. And then related to methamphetamine directly and HIV, risk of HIV acquisition and transmission, this was a study where they took data from this already established national internet-based cohort called Together 5,000. So this was it's a cohort of 4,786 men, trans women who have sex with men, and they looked at baseline HIV screening tests and also surveys where they asked about methamphetamine use and sexual practices, and then 12 months later, repeated the HIV screening test and the same surveys. And they found that persistent methamphetamine use throughout the study period accounted for 1/3 of all HIV seroconversions. And there were 115 total seroconversions, 41 in people who use methamphetamine. And again, as I mentioned before, here in the West, we have the highest rates of methamphetamine use in the country. And then this is a study from the amazing substance use treatment team at the Owen Clinic. This is made possible with some funding from a San Diego CFAR supplement. And we performed a retrospective chart review where we characterized methamphetamine use among our entire patient population at Owen between July 2022 and June 2023. And we found that the prevalence of use in this cohort was 17%. So I think quite high and perhaps underrepresents the use. We defined methamphetamine use by either a positive urine drug screen for methamphetamine during the study period, or an encounter, like a visit encounter that had methamphetamine use or use disorder linked to it. So, a visit at Owen. So may have underrepresented the true prevalence. But anyway, amongst our patients who use methamphetamine, they were far more likely to miss scheduled HIV primary care visits, screen positive for Hep C antibody, which used as a marker of shared injection equipment or higher risk sexual behavior. More likely to screen positive for gonorrhea and chlamydia, which we used as a proxy for condomless sex, and then also screening positive for major depressive disorder, because we know that treatment of substance use disorder is far less effective if you're not treating the underlying mental health disorder. And then finally, people who use methamphetamine in our cohort study were less likely to be virally suppressed and more likely to have a CD4 count less than 200. And then this is some data from a few years ago from Philadelphia, but I think it's important to look, at what they've done and processes and programs that they've implemented, because they're about 10 years behind us and when fentanyl actually hit Philadelphia. And this was a study there looking at hospitalizations in all of Philadelphia between 2013 and 2018, and they showed that the number of hospitalizations for serious bacterial infections increased exponentially during this time period. And that's because fentanyl really hit Philadelphia about 2012, 2013. But during that same time period, bacterial infections in people who did not use drugs, they did not see similar increases. And then this is looking at of those people who were admitted with serious bacterial infections, what percentage left via patient-directed discharge. And I think these numbers are quite alarming, but amongst patients admitted for things like skin and soft tissue infections, infective endocarditis, osteomyelitis, and bacteremia and sepsis, there's significantly more left via patient-directed discharge if they had a history of injection drug use compared to those who did not. And the timing of these patient-directed discharges was really the first 2 days of hospital admission. So greater than 50% who were hospitalized for these serious bacterial infections left during those first 2 days. And what that tells us is that we're not treating withdrawal properly, we're not treating pain properly, and patients are leaving because they come into the hospital and they start to feel worse than when they presented in the first place. The lessons that we can capitalize on here, I think. And then what else are we doing in the hospital that really doesn't support patients staying to get the care they need and deserve? So as you're all aware, there's a lot of mistrust and fear and stigma that is faced by people who use drugs, and so that delays them seeking care, and then it can lead to increased disease severity when they do present to care, and missed opportunities for early intervention. As I mentioned, there are people who use drugs have higher rates of unplanned or patient initiated discharge compared to the general population. And again, some of these reasons are inadequate pain control, withdrawal management, negative interactions with us or security who come in and search their belongings, and experience of hospital restrictions, not allowing visitors. That just helps people be more comfortable in the hospital. And patient-initiated discharge represent this opportunity for us to engage and build trust, because when people leave via patient-directed discharge, it does result in greater 30-day readmission rates and 30-day mortality. And we're really a critical touch point, because a lot of patients who use drugs don't have primary care providers, and they do use the emergency department in hospitals for both management of acute and chronic conditions. So there's a push here at UCSD to increase all of these services, a lot of services for people who use drugs. And this is based on a new Senate bill that Governor Newsom signed in October 2023, but it's going into effect in San Diego in January. And so what this bill is, this makes changes to a 1967 act called the Lanterman-Petrus Short Act. And it's a law that governs, pretty much the law that governs the involuntary detention, treatment, and conservatorship of people with severe behavioral health conditions. And so this study updates, this greater than 50-year-old bill is to establish new criteria and broaden the definition of grave disability. The definition of grave disability is someone needs to be a danger to themselves, a danger to others, or have grave disability. And for the purposes of involuntary commitment, this law defines gravely disabled as either a condition in which a person as a result of a mental health disorder is unable to provide for their basic needs, like food, clothing, or shelter. But this new law expands that to include substance use. And so the new law, can be defined as gravely disabled if you have a mental health disorder or a severe substance use disorder or co-occurring mental health and substance use disorder, and you're unable to care for your basic needs. So I think it's still a bit unclear of, what this is exactly going to look like, but I hope at the very least, I think, those of us who do any inpatient hospital time know that, people seem to be pushed out the door, too quickly, before we can really come up with a plan to treat people and get them into post-discharge care. And so I think at the very least, we can use this as leverage to say, hey, we got to keep this person a few more days so we can start substance use treatment, so we can get them linked to substance use treatment. All right, and this is, yes, Jill.
Just with respect to that, will that also, I think one of the things we talk about is often being very difficult is the transition from inpatient to some place. Is this meant to help with some of that support, to back to care? Can you talk about?
I just want to make myself a quick extra high.
So this is kind of what it looks like in San Diego. Again, Governor Newsom signed the law in October 2023. It's going into effect here in January, and the city has said they want to expand education and training. They want to expand treatment services and support for those with substance use disorders, establishing alternatives to emergency departments for 5150 goals to try to get people directly to substance use treatment. And then finally updating some of the procedures and support capacity for the Office of the Public Conservator. And then this is UCSD's plan. I'm trying to insert myself as much as I can into this and some others here at UCSD, like Carla Marienfeld, who's our only addiction psychiatrist at the moment. But there is a team who's working on this here at UCSD, and some of their priorities are to establish strategic partnerships to facilitate timely discharges. Little bit counter to what I think this is supposed to be. Expansion of case management and social work services. So Renee, Justice Royster and Chris Miller. So Renee is our behavioral health counselor at the Owen Clinic, and Chris Miller, one of our social workers, have already done a training session for our hospital social workers. I think Renee and Chris know more about the substance use treatment programs in San Diego than anyone I know. And so they've given them a great overview of all of those programs and a checklist of what people need if they're going to be transitioned to either residential treatment or an outpatient program. Do they need an ID, which insurance, all the practical stuff, which insurance do they need? Do they need a quantiferon TB test? And we've really implored the social workers to get on the phone and call the programs with the patients. Just don't hand them a piece of paper and say, call these numbers. So we really have a smooth transition when people are started on substance use treatment in the hospital, that they can continue. And Renee and Chris did the same talk for our fellows, and they're also going to do it again for our psychiatry liaison service on the inpatient side in December. And so that feeds into some of the specialty training for the psychiatry providers. So right now, it will be the psychiatry liaison service will help the most with this. We are working really hard to build an addiction medicine service as well. But I did some training for the alcohol use disorder and methamphetamine use disorder. One of our really
breakfast.
Psychiatry pharmacists did a really great lecture on opioid use disorder. I can share those slides with everyone. And then increase awareness harm reduction services in the community for patients and families, making fentanyl test strips available and syringes, and then working on some legislation and policy affairs. All right, so I want to thank Afsana Karim. Oh, you have a question?
Yeah,
I
doing
think
it now.
Yes.
Just a little confused and sorry if I missed this, but some of that is gonna be involuntary, because when someone's transitioned out, they're gonna have to be voluntary to
Yeah.
stay at a
Yeah, I
facility.
think it can. I think how this all plays out is gonna be a little bit unclear, but yeah.
I didn't want to interrupt, but I do worry about some of the earlier comments you had about the experience of people with substance use disorders in hospitals, how their pain is not treated, how they are kind of just treated as usual. And then if you kind of involuntarily
Yeah,
mandate them to
Yeah.
get treatment as usual,
yeah,
you are theoretically or have the great potential of of perpetuating that harm.
yeah.
And, you know, maybe there will be a few people who are more educated or trained on it, but I think
Yeah.
the system doesn't work that way.
Well-
So very much I'm, worried about that.
And I'm gonna get to that. So we have some plans in place that we are really, there's some I'm gonna talk about some really cool initiatives around the country and how we might be able to capitalize and, utilize those initiatives here. So this is some data, and I thank Afsana Karim for helping me pull this. But these are admissions to La Jolla and Hillcrest. I don't have East Campus numbers because we'd become fully integrated with East Campus until July, but these are numbers from October 2023 through November of this year. So above is La Jolla and Hillcrest. So these are admissions in people with substance use disorders. So I asked Afsana to pull any hospital encounter that was linked to alcohol use or use disorder, methamphetamine, opioid. And so there were close to 7,000 admissions in this last year that, and this might underrepresent it too, that were substance use related. So that's almost 13% of all admissions at both campuses. 6% left via patient-directed discharge, via less than 1% without a substance use disorder. And then you can see the difference in 30-day readmission rates, 16.5% versus 7%. If you look at Hillcrest alone, almost a quarter of all admissions we see here are, and I think we all know that from being on service here. And again, much higher rates of patient-directed discharge and 30-day readmissions. I'm gonna dive into this a little bit more and see when are these patient-directed discharges happening. We're using all of this. Mortality data is a little bit harder to track down, but using all of this to argue for the creation of an addiction medicine service and some of the other interventions that I'm gonna talk about. So I think the most important thing, and this comes from Dr. Nora Volkov, who's the director of NIDA. She has this really amazing blog. And this is, I think, first and foremost, and what was left out of that UCSD plan is actually involving the people who use drugs in these decisions. I think that's today's point. What do people who use drugs want? How do they want the care delivered to them? And so, you all know both medical research and clinical care can become disconnected from the interests and needs of the people that we intend to serve. And so really asking them, how do they want surveys created and delivered, or the services created and delivered to them. And then this is an order set that I led the creation of. And so this is really intended to improve the overall care of people who use drugs in the hospital. And it has multiple components. So, and only one component is really the substance use treatment. And so for people who aren't ready for substance use treatment, they can still benefit from other aspects of this order set. So the first part is consults, and that's where you'll find the social work consult, and I'm asking the residents and hospitalists to get social work involved from the first day so that people can be linked to care afterwards, and also psychiatry consult is in there. And then in lab section, There's also urine drug screens, but also HIV screening, viral hepatitis screening, STI screening, and a quantiferon TB test if people are linked to residential treatment. Diagnostics is an EKG for starting methadone, because methadone can prolong the QT interval. And then meds for alcohol, opioid, methamphetamine, and tobacco use disorder. And a lot of these are, come from ASAM guidelines, the American Society of Addiction Medicine, the California Bridge Program guidelines, and some new like meta-analyses. I just want to point out in particular the opioid use disorder section. We've really streamlined this, and there's really just two pathways for starting opioid use disorder treatment in the hospital. And one is what we're calling now standard dose Suboxone, which is once someone is in at least mild withdrawal, you start them on 8 milligrams of buprenorphine, you give them 8 and 2 milligrams of Suboxone every 2 hours, get them up to 24 milligrams of Suboxone that first day, so they're really comfortable that first day, and then continue at 24 or 32 moving forward. We do see a lot of people, the other pathway is this low dose overlap pathway. We see a lot of people who get full agonist opioids in the emergency department or in the hospital for pain, but still want to start Suboxone. So there's the second pathway in this is you give a very low doses of buprenorphine, like microgram levels. And what you do is you continue the full agonist and you're slowly increasing the buprenorphine while you're continuing the full agonist. And once you get to that 24 milligrams of buprenorphine a day, you stop the full agonist. So again, people are comfortable, they're not in withdrawal, they're not in pain, and hopefully are staying to get the care they need and deserve. And then finally, the last three sections, just some adjunctive meds to treat withdrawal symptoms. I didn't break it down by substance, but like all PRN meds, just by things that people, symptoms that they report. So they're meds for diarrhea, anxiety, muscle aches, like, any withdrawal symptom that could be associated with stopping substance use. Vaccinations, there's tetanus, pneumococcal vaccine, and Hep A, which are all more common in people who use drugs. And then finally, discharge orders that include Narcan and syringes and alcohol pads and Chantix and a smoker's helpline. So hopefully everything that someone would need to improve the care of people who use drugs in the hospital. And then we're going to look at this pre and post pre and post order set to see if we've increased rates of all of these things: screening, MAT initiation, discharge orders for Narcan. All right, and then this is an interesting paper from New York City. Believe it or not, there's not much data out there to support addiction medicine consult services. And the reason is that the American the American Board of Medical Specialties didn't recognize addiction medicine as a specialty until 2018. So not much to study before then. But anyway, this was a stepped wedge cluster randomized clinical trial at 6 public hospitals in New York, where they compared patients who had access to an addiction medicine consult service in the hospital versus those that did not. And what they found, not surprisingly, is that those that participated in the intervention, had addiction medicine consult service access, had significantly higher odds of initiating medications for opioid use disorder, and also significantly higher odds of remaining engaged in substance use disorder treatment post-discharge. And this is a really cool clinic at the University of Florida that was started in 2012 by a hospital there that got a low income population federal grant. So it's kind of like the Owen Clinic. It's kind of like an intake visit at the Owen Clinic where patients, see multiple providers at once, pharmacists, our financial counselors, our care navigator. But this is a post-discharge clinic where actually all the specialists go to the clinic. So the patients don't have to go to multiple clinics, and it's staffed by hospitalists, addiction medicine specialists, and multiple other specialties. Someone with endocarditis could see their ID doc, or someone with pulmonary hypertension could see their pulmonologist. Patients can spend 3 or 4 hours there, but a half day, they see everybody that they need to see. And what they found is 6 months after they initiated this clinic, they reduced emergency department visits by 11%, hospital readmissions by 25%, and length of hospital stays by 23%. And actually, of the 206 patients who accessed this clinic, they estimated that they saved $1.8 million, by reducing all of those visits and hospital stays. All right, and this is another great strategy. I think, again, like maybe to Dave Galati's point of, we've got to do different things. We can't just have, expect to hold people involuntarily and just give them, what is the current standard of care. So this is an interesting paper, again, from Philadelphia, from Temple, which introduces the idea of utilizing high dose full opioid agonists, like oxycodone and hydromorphone in the first days, like the first day or two. Remember, that's when the highest, highest patient directed discharge rate were happening. Introduces that in the first day or two, specifically to treat opioid withdrawal. Because in Philadelphia, they talk about fentanyl use, not based on like how many bags a day, but based on how many bundles a day. And a bundle is 10 bags of fentanyl, which is about a gram. And people report using 2, 3, 4 bundles. So it's, I think, significantly higher use than here, given the purity of the fentanyl and just kind of how long the epidemic has been going on there. But what they've found in places like Temple, where this comes from, is that they really have had a hard time starting buprenorphine because it's only a partial agonist, and it just does not overcome the potency of the fentanyl there. And so what they're doing, again, is starting oxycodone and hydromorphone, and then once people are comfortable and out of withdrawal, then doing that low dose overlap where they slowly increase the buprenorphine while continuing the high dose agonist, and then just stop the full agonist. And, like I said, so then they can transition to buprenorphine, or for patients who want to transition to methadone, no problem, they can just start on methadone. They've also found in Philadelphia that, and even here, that it's even hard to start patients on methadone, which is also a full agonist, but the protocols that we use only start at 30 milligrams of methadone, which again is very little. We just can't get methadone increased, rapidly enough to really overcome the severe withdrawal that people are experiencing. So this article is interesting. It's a point counterpoint, and so Sam Stern, Joe DeRazio, Brian Work are, they're arguing for this new process, but then Dr. Calcaterra and Sakar, she's from the University of Colorado and he's from Penn, argue that, this isn't, we shouldn't be using full agonists to treat, opioid use disorder. But again, like, my friend Brian, I talked to him last week about this. He said, this is we really need to make the distinction that this is treating withdrawal. We're treating the withdrawal, we're treating the pain to stabilize someone and then get them on buprenorphine, get them on what are the FDA approved and standard of care. All right. And then this is just a few other models. So some bridge clinics, kind of like that Care One clinic, but there have been a number of these. Again, not a lot of, not extensive evidence because they're all pretty new, but some of these bridge clinics, they can be hospital-based, and this can just, patients can have a single visit to bridge them to, longer-term substance use disorder treatment program, often because waits to get into the substance use disorder programs can be weeks to months, and so that they can at least see someone once or twice to continue the substance use treatment and then bridge them to to the long-term clinic is really helpful. I think the California Bridge Program is the best example of the emergency medicine-based bridge programs. That funding has gone away a bit, unfortunately, but there's a really nice study where they enrolled 12,000 people with opioid use disorder, across California. 60% initiated, buprenorphine, which is incredible. I told you before, only 6% overall in the US initiate treatment, and 40% were retained in care. So these programs are, very successful. Another great model, which we're trying to employ here, is this pharmacy bridge model. We don't have access to long-acting injectable versions of substance use treatment in the hospital just because of the cost. But if someone started oral alternative in the hospital, could they just swing by the discharge pharmacy out the door and get, long-acting injectable naltrexone or long-acting injectable buprenorphine, which buys us 21 to 28 days to link them to another program. So we're working on that, and I think the pharmacy department is coming around to that. All right, so again, they've been highly successful. There's still limited data on linkage to long-term care and substance use disorder treatment retention, because a lot of these models are so new. And also not a lot of data yet on outcomes, on other outcomes related to substance use disorder treatment, like reductions in HIV acquisition or Hep C acquisition, or reductions in serious bacterial infection. All right, and this is the last model. This comes from, this is at the University of Miami. And this is an integrated infectious disease and substance use disorder treatment model for individuals with severe injection-related infections. So they integrated this a few years ago, and then were able to outcomes amongst people that were admitted to the University of Miami before the integration of this program and after. And there were 129 patients included in the study. 59 in the series team intervention, and 7, prior to access to the intervention. And what they found is that, their primary outcome, they looked at 90-day mortality or readmission. They saw a significant, a 44% reduction in both mortality and 90-day readmissions when people had access to this combined substance use and infectious diseases treatment service. And then secondary outcomes, readmission, we saw a 59% reduction in readmissions and a 47% increase in completion of antibiotics. And this team at the University of Miami, they're expanding this work. They're working with some of my colleagues at Penn to try to do, to implement this here or there. Sorry. So something also to think about here. I'm sharing like a lot of these different models here, and which we land on unclear. But I think that the enormous success of these, and we don't need to reinvent the wheel. I think we can see what's going to integrate best into UCSD. Yes, Dave.
I'm curious how this started and how it's sustained. Because, a lot of times these are grant funded projects, and when the grant ends, so do the projects. But, are there lessons to be learned by, if this wasn't grant funded, how did they get it done? And if it was grant funded and it ended, how did they keep it going?
Yeah. I think just, I think the majority of the physicians, part of this study are also addiction medicine trained. So they just do both when they're, and they're seeing I think there's a few of us that are doing this already, and I see someone who also does make comments about, the substance use treatment, but I don't know that needs to be I think it really, we should think about it as it's really part of the standard of care. I always say that, we comment on diabetes. If someone's hemoglobin A1C is 15 and they have an infection, we're commenting on improving glycemic control. I think we should also comment, if the endocarditis, if the cause is really the injection drug use, I think it is our responsibility as infectious disease specialists to help treat that.
I think most of us do that
Yeah.
part. I think it's the patient navigation piece and
Yeah,
it's the, for lack of a better word, just at UCSD, the not having Courtney Thompson on the other side. I
Yeah.
think the handoffs, the linkages, that is what is so hard.
Mhm.
And if someone doesn't stay on top of that very closely, we lose patients.
Yeah.
And to me, that's the biggest piece of it,
Yeah.
and obviously we all need to get on board with this.
And Renee also, who often visits people.
Yeah, well, and not right, and that's just right, and y'all have been wonderful about coming and seeing people, but having that for everyone, right, who is interested in talking to someone. Thank you for
Mm.
bringing Renee and Chris.
And I think they are hopefully part of this SB 43 is increasing the social work, increased management presence. So hopefully we'll have, maybe not navigators, but at least someone who is helping people link, and giving them like you're gonna get discharged tomorrow. Here's your appointment, 11 o'clock to go right to the treatment program. Yeah.
Here's the cab I'm gonna put, here's the lift I'm
here's
gonna
the
put you
list.
in,
Yeah,
here's.
and we can do that. Yeah, I can do that. Yeah. Communicate.
So, going back to the study that you presented on treating, like with full agonists in the first 2 days, I find that very interesting. It's like a little bit thinking outside the mold for a lot of us, and, it would be amazing to explore this further, in the Hilton patient population. But I see a lot of resistance. How do you think, how, I see, the hospital being like, this is only going to go against their incentive of just trying to get people out the door. So how can we argue against it or overcome that incentive?
I mean, I can work with the folks maybe I can get some of their data and, yeah, is it a decreasing or increasing length of stay? But I think we can leverage SB 43 to say we need to increase the length of stay, this admission to prevent subsequent admissions. The other thing is that, I think the concern also is that, we're gonna, cause someone to overdose on these full agonists and talking to my friend Brian, they've had countless people overdose on fentanyl in the hospital and die at Temple. And we have here too.
Right.
They've never had someone overdose on oxycodone or hydromorphine that they've prescribed.
We have can I do one question from here? Sorry, they've been sitting for a little bit, and then to Lucas. So Nettie asked about how SB 43 could impact outpatients who are gravely disabled by substance use disorder, and are on the, streets, but not in the hospital. What kind of impact might it have?
I mean, it could potentially mandate treatment, I guess it's like how, it's gonna be interesting to see how this plays out, because, but I think that's the goal. But yeah, I think I have mixed feelings about that if because also we know if people aren't really ready, whatever that means, whatever reason, the treatment may not be as effective.
And just along those lines, sorry, what was the discussion about? This is gonna overwhelm the mental health system, and I mean, I don't know that we're building the facilities that are needed to round everyone up and get them into county mental health. So.
Yeah, I actually have two questions. One of those is exactly kind of along what they were just saying, but like, I'm curious if I find it interesting that the legislation signed was tied to increasing the ability to involuntarily hold people. And so what was the purpose of the legislation? And was it to really increase access to services, or I'm not saying there's a nefarious intention, but they could have gone a lot of different ways with legislation to create access to treatment, and they went with something that increases our ability to involuntarily hold people.
Prisons have clinics.
I'm just curious, if what was the path that, why did they go that route? Because it brings to mind, you hear patients who come to clinic and they're like, yeah, I was in TJ, they threw me in a facility for 30 days, they wouldn't let me out, and they forced me into, recovery. And I'm not saying that's where this is going, but it is interesting that we're talking about increasing the ability to hold people because of substance use.
No, I
Yeah.
don't know the motivation, but hopefully it was,
We did have someone speak about this last year. Sorry to interrupt, but we had at this AIDS rounds last year, a kind psychiatrist give us a talk about this bill and explain that the goal was to be able
Right.
to include grave disability and not exclude substance use when someone is gravely disabled. It needs to be in the hospital, and the psychiatrist can't admit them because they say, oh, it's grave disability due to substance use. So just to be fair to, it's not for rounding people up, but he gave a very nice explanation. I think it was last year. So it was really because people who are unable to care for themselves were not being able to be hospitalized because there's sort of exclusion of including substance use as a psychiatric condition.
Yeah, that's right, Nettie, and I'm hopeful that it'll give us leverage to say, hey, you've gotta let this patient stay a few more days. And what I didn't mention is, in those like low dose overlap protocols, there's a 3, 4 to 5 day, 6 to 7 day. It's really based on projective length of stay. And clearly the longer you can, the slower you can do these, the less chance of precipitate withdrawal. So perhaps we can really leverage, hey, we really need to allow this person to stay in the hospital 6 to 7 days to do this properly.
And I know that this still probably, it sounds like it's a lot of it's in the works, but like, has UCSD talked about, if you guys feel this person does need to stay, does that mean it still has to go the route of a 5150 type process to get them to stay, right? Because talking about potentially using the need to involuntarily hold someone as a need to get them to stay longer for treatment. I'm trying to say, like, how does that process work and, within the hospital?
Right.
My other question was, 25% of almost 25% of our admissions at Hillcrest are for substance use.
Yeah.
With 3 times the readmission rate as everybody else. What's
we
your
got that new
opinion why
building.
UCSD is not investing more in dealing with, like an addiction medicine service seems obvious to me. Is it purely stigma or is it, or is it more complicated, I'm sure, than that?
Well, I haven't presented this data then yet. This is all very new. So I don't know that, I don't think it even occurred to them to look at, and
I mean, they're aware that the readmission rates are
Well,
driven by, they just had in the data.
They keep, I feel like I was asked to sit on one of these committees briefly, and then for some reason I wasn't invited back. But they kept talking about, it's about access, like your gastroenterology appointment is 60 days out. And I'm like, it's nothing to do with that. This is what is driving it. Yeah.
Well, I don't want to comment on the health system's motivations, but I did see a comment pop up from Miley about money, priorities, the kind of way that San Diego actually categorize or puts folks into different bins. So, contracts with outside agencies to do this kind of work, and UCSD doesn't, I don't think, get a lot of these contracts, so I don't know if there's much motivation. This might be an opportunity though, SB 43, for them to kind of rethink that. But I did want to say one thing, going back to your prospective kind of evaluation of the order set. Could you integrate patient perspective into that as well? Because a pro or something like that for patients would be, I think, very interesting to see, especially since, we're talking about, thinking that this is actually what they want. And I'm not sure this will be an experience that they come back and cherish, based on like the way the system works.
Cherish.
I just want to say, there's a bunch of more comments through here. So, Eric O'Leary from COSD, I guess Behavioral Health Services, gave a brief overview. Dr. Esposito gave a brief overview of SB 43. She said those accessing services like outpatient treatment, harm reduction, et cetera, can use that for the defense that they don't require involuntary holds. I guess, this is back to what we were talking about. I think the way I think this is all gonna be very interesting to see the way this plays out and how it's being used. And I'm sure there's gonna be I have a feeling the ethics service at UCSD and other places are gonna have to be involved in, all sorts of things like that.
Yeah, and I'm just hopeful that it
Yeah.
increases resources,
Yes.
and we did get some limited funds, like, we got like $300,000 from the county and like to hire 2 new social workers and a care
great.
navigator, but there,
That's
yeah,
fabulous.
so there are some things happening.
One time or per year?
What,
One time or per year?
per year?
Yeah, is Winston?
I don't. Sorry, I'll look in a second. Sarah Rojas asked about outpatient addiction medicine clinics at UCSD for underinsured patients and where we're sending patients when that's an issue.
Yeah.
Great
so-
questions, Sarah.
Yeah, so I'm hoping we can do something like that Care One clinic. I mean, that has been a discussion. The hospitals who started at University of Florida did come and speak to a group. It's like an overutilizer group, not a great name, but they're thinking about this. But so that's one option. And then there's a whole, like I said, Renee and Chris Miller presented a whole bunch of clinics to our social workers. There's a whole network called Acadia that have multiple sites that do buprenorphine, naltrexone. So there's a whole network and we're working on
I
it.
think the answer to Sarah, though, is the only place that does that at UCSD would be Owen.
Well, it's
Clinic.
Owen Clinic.
Currently, and that
Currently.
may change, but I also saw, oh no, that was behavioral health services, never mind, sorry. But I
Yeah.
think we also try to get people linked to San Ysidro Family Health Centers, all these other places that have clinics.
Yeah.
I just don't know how great those handoffs
Are you
are.
talking about for medication assisted treatment?
Yes,
Oh, yeah, we
Yeah.
have a whole list of places that, take, county funded,
Yeah.
the people that are underinsured.
right,
Have they been able to like get it sort of that week, like we were talking about,
Yeah,
you know,
for like
immediately?
Acadia, they can go
Yeah.
that week,
Right.
they can get in pretty fast.
Nice.
They have walk-ins.
Yeah.
like, yeah.
Start at 5 o'clock in the morning.
Yeah.
I think if I can add a couple of things, it's interesting because the grave disability part of substance use, it might actually give some of our patients an opportunity to treat their more severe withdrawals, because a lot of our underinsured patients don't have opportunities to go to full medicated rehabs. It's really like it's sober living. And we can't get them those type of services as an outpatient. So I can see an opportunity here, but it's one of these things where you watch that if you're not appropriately supporting all the aspects of this cascade. So it's great that you have a hospital service, but if we don't not just have linkage, but we need the programs that you're linking to be supported. And it sounds like you're saying the community resources, and that's a lot. So I hope that there's definitely a community perspective being represented here, about how we're going to be more resourced. And also, I hear a lot of injection drug use, but not a lot about meth and where we are with medication assisted treatment and treating meth, right? So Suboxone's a lot easier. We have our Acadias, we have our methadone, et cetera. But without like, I would just love to see UCSD leading the way for more meth addiction treatment.
well,
I think you are, but but it'd be.
Sarah, I think there actually are a few studies going on. It's 9 o'clock, so I don't know if we have a lot of time to talk about that. I don't know if you wanna.
But they're doing that. They're doing
Yeah.
The order set too, Sarah. We have naltrexone, the combination naltrexone, bupropion, and mirtazapine are all in the order set, and we probably do more of that at Owen than opioid use disorder treatment. Yeah.
Well, let's think about that 43.
Yeah.
Makes me think about our one patient that used to come to the clinic with
Yeah.
all his papers and stuff like that.
Oh, yeah.
That he seemed most appropriate for the SB.
Yeah, that's
The
true.
one with all the papers
All the
outside?
papers,
Yeah.
Yeah, he got the help that he needed, so I think that it would be someone like that.
Yeah.
Yeah.
All right, well, it's 9 o'clock. Thanks everyone for joining. Oh, sorry, Ollie threw something in at 9:01. I believe all 30-day readmissions are penalized.
Comment before about.
Are there financial penalties? Thank you.
Yeah.
Sorry, y'all are throwing stuff in way too late. You gotta come in person if you wanna do it. Sorry. I'm joking. Thanks everyone for joining. Thank you so much. Really appreciate it. We'll see you next week.
Next week is Thanksgiving.
We'll see you next week. We'll see you the week after.
Yeah.
2 weeks. Happy Thanksgiving, everybody.
If you didn't